to finish it off faster. Anyhow, thank you for having me over. And my counterjection to Dr. Mujibur Rahman would be that increasing use of laser is not actually very beneficial. So what is an ideal surgical technique? An ideal surgical technique is one which is applicable for everything. It is accessible to everybody. It is extremely cost effective, and majority of the surgical fraternity is familiar with this. So the answer to all these questions is a standard or a classical TURBT. Coming to applicability, so we all know tumors come in various shapes, various sizes, various areas. They can be at the ureteric orifices, they can be at the dome, they can be 3 centimeters, they can be 7 centimeters. TURBT is a one-stop solution to tackle all these tumors. There are no limitations, probably apart from very large sizes. Apart from that, you can do everything with a standard TURBT. The issue of location, as Dr. Rahman correctly mentioned, that this is a paper which was published in 2016 in the EAU, and this basically says that 30% of the tumors might not be amenable for resection by laser, especially with the ones which are present on the dome, anterior wall, near the bladder neck, and high up posterior tumors. While TURBT, you know all the tricks of the trade, and you will be able to get away with doing a TURBT for tumors at any location. The issue of size, you can see the image on the left side, so you can imagine, I mean, it's going to be extremely difficult to do an en bloc laser resection for this particular tumor, but again, a conventional TURBT is very much possible. Majority of the laser TURBT studies, as Dr. Rahman correctly said, are limited to tumors which are around 3 to 4 centimeters or less. So larger tumors, you do not use lasers. So the issue of applicability is definitely there. The larger the tumor is, the more difficult the en bloc resection is. There would be naysayers of this statement. They would say that we can tackle any size of tumor with the help of lasers, but applicability and widespread usage. So every person should be comfortable, not 1 or 2 people who are extremely good endodissectionists. Specimen retrieval is a very, very bothersome problem. So if it's a large tumor, you would have to do certain additional endeavors, like you have to morcellate, you have to pull through the urethra, you have to splice, and it's just not the pressure which causes dissemination of these cells. It is the splicing, this playing, which ultimately leads to the tissue handling, which ultimately leads to the dissemination of cells and the implantation theory. So why are we actually doing this? In larger tumors, I strictly believe lasers is absolutely of no use. And then coming to the next point, which is an en bloc resection. So is en bloc resection not possible with a conventional TURBT? Yes, it is. There are multiple techniques which have been described. You straighten the loop, you bend the loop to a acute angle, you will be able to do a conventional en bloc resection. And this is one image which I took it from the journal because this was from the Manipal hospitals, and they have devised a scissor called Z scissors, and with the help of which they are giving beautiful and en bloc specimen in TURBT with minimal cautery artifacts. So yes, en bloc is definitely possible without the effect of charring by a conventional technique. You can also modify your conventional TURBT and go under the muscle, and you will be able to do an en bloc resection. So the specimen quality, which is generally given by the presence of the detrusor muscle, has been shown to be very good. Coming to the bipolar TURBT, there have been studies, there have been conflicting studies actually. So the one which Dr. Rahman showed said that it is marginally better than the conventional TURBT, but if you torture the data long enough, you will find some studies which are corroborating that bipolar TURBT is way better than a conventional TURBT. The reason being, the charring is not there, which is there in a conventional TURBT. So once the charring is not there, the detrusor doesn't get desiccated, and the pathologists are able to pick up better. This is because of the plasma kinetic effect of the bipolars, and multiple techniques have been described. I would not go into details of those techniques, but this is a paper, this is a seminal paper which compared the efficacy of the conventional monopolar TURBT versus a bipolar and a holmium. And they found that the incidence of the obturator jerk, the incidence of bladder perforation, bladder irrigation, catheterization times, hospital stay, and the detrusor muscle sample in bipolar TURBT is equivalent to the laser TURBT. A very important topic, cost effectivity. India is a very cost sensitive country, and our patients are very, very cost sensitive. So the cost of the laser, it is not affordable to have by every urologist. The cost of disposables and equipment, you are making a procedure costlier. At what price? I mean, you are actually not picking up the detrusor to a larger extent. If you're doing a good conventional TURBT, your pickup rates are going to be probably similar. The packages of the hospital, is laser allowed in TURBT? At least in my hospital, I cannot do a laser TURBT and charge extra from the patient. Insurances, again, they're going to put their foot down. Why are you doing a laser TURBT? You can do a conventional TURBT. The entire world is doing a conventional TURBT. Why do you need a laser for a TURBT? And the government-sponsored scheme. Every state is basically now, governments are sponsoring certain oncological surgeries, and lasers are not there. So how do you justify the use of lasers in those schemes, patients? So is the increased cost of laser TURBT really justified? Issue of familiarity. So TURBT, a conventional TURBT, we are all trained in a conventional TURBT. Every student which we have is, TURBT is an essential skill to pick up. Lasers are not available. I come from West Bengal, and West Bengal, believe me, there are 4 medical colleges, all have lasers, but probably none of them are functional. Reason being, they are not taken care of, the disposable equipments are not there, so where is the training going to happen? Medical colleges do not have functional lasers, how are you going to train them? But yes, a conventional TURBT, you ask any student of final year, he'll be able to do a largest of the tumors in a very good way. So that is something which we have to consider. And again, a bipolar TURBT requires no special training, so you can actually do a bipolar TURBT and get results which are as good as laser TURBT. Issue of learning curve, nobody mentions this, but issue of learning, so if you want to do a good TURBT, probably 20, 25, 30 cases are good enough. If you want to do a bipolar TURBT, again, you do not need any special skills, so it is just 20, 25 cases. You just have to change your energy source. But if you are doing a HOLEP, I'm extrapolating that, but you require about 100 cases. So on your left, you can see this is the learning curve of HOLEPs. You require 100 cases. So what is the learning curve of an unblocked resection on a TURBT? Probably higher. So how many cases a resident is going to have during his training so that he can pick up a really good on-block laser TURBT as compared to just 20 cases required for a conventional TURBT? I believe there goes your answers.
So last 1 minute.
Right. So the critique of the data. So majority of the data which Sir has quoted is from smaller studies, a smaller cohort. And pooled data is always subjected to bias. The clinical relevance of having a day shorter of a hospitalization, days shorter of a catheterization are probably not very important, and they're also dependent upon the surgical factors, the surgeon factors, the institution protocols, and the insurances. Now, this is a data from a very high volume center. You can see the overall complications across all the types of TURBTs are exactly the same, as well as the detrusor pickup rates are almost same, 95%. So a high volume center can give you a better results with a conventional TURBT also. This is our own data. So we analyzed around 450 patients who underwent TURBT over the span of 10 years. The overall detrusor pickup rate was 86%. But once we analyzed the subsets, so we analyzed how good a surgeon was doing. So my pickup rate was around 98%. But once we club everything, it comes down to around 86, 87%. So the surgical experience also matters. So long-term follow-up has been exactly the same. So do we still have a justification of doing a laser TURBT? Because the overall recurrence rates are absolutely same. So this is my last slide. So to conclude, conventional TURBT can resect any tumor, so there's no shape, size, location botheration. It is an essential skill which everybody knows, and I'm sure that you can do a good job with it. In experienced hands, the outcome of detrusor muscle pickup rate is extremely the same. Unblocked resection is possible even without lasers. Bipolar TURBT can give you as good results as laser TURBTs with all the benefits which I have already enumerated. Conventional TURBT is cost effective and it is viable in this country. The recurrence rates are absolutely same, then why we are using the laser at all. Thank you so much.
Thank you, both the speakers.
Thank you, Dr. Tarun. Sir, the chairpersons, may I request you to please give your concluding remark or ask one single last question, because we are run out of time.
Sure, thank you. There is a good saying about anything, which is like, if it is not broken, why to fix it? We have been doing TURBTs, and if you are well experienced, you can do it well. There is no debate involved in this, I think, because if there is no oncological, this is an oncology conference, if there is no oncological benefit in any specific procedure, why do we discuss? Same debate used to happen about TURP and laser HOLEP or green light. It has had its own death, you know. So I think same thing is happening here. There is no debate involved in this. We know that if whatever works for you, I think that you should do it. There is no oncological benefit. Time will tell us if there is any additional advantage. Thank you.
Thank you so much, sir. We come to the last debate of this session, which is on partial nephrectomy should be offered whenever feasible, yes or not. Dr. Himang Bakshi will be talking in favor of it. He's a consultant and head uro-oncology and robotic surgery at HCG Cancer Center, Ahmedabad. Seven minutes each speaker and 6 minutes for discussion. If you exceed your time, there's less time for discussion or no time. Thank you.
Well, I understand. I had prepared this talk keeping 10 minutes in mind, but I'll rush through my slides. So I thank the organizers for having this topic given to me, which is close not just to my heart, but also to my brain and to the fingers of my console. So the debate is whether we should be doing this partial nephrectomies in wherever we can. We should be treating the patient as a whole and also thinking about long-term outcomes of minimizing CKD and overall survival, apart from the oncological benefit. So I'll go through the slides in this flow, arguments first, followed by evidence, technology, and what the guidelines say. Now, what we are debating is clear, which is the one in the red, T1B and T2. T1A is almost always a nephrectomy. I think there is no debate about that. Partial. Oh, I'm speaking for the other side. I've made a self-goal, I guess. But so T1A is always a partial. T1B, T2 is the center of the debate. T3, T4, we rarely do it. It's all the pressure of sticking to time. Now, what my accomplished colleague will argue in complex tumors, if you are presented with a CT scan showing the other contralateral kidney is normally functioning, why would you want to do a more complex operation? But is that kidney really working well? Because the conventional wisdom that patients do well with one kidney is based on outcomes of healthy patients who have undergone rigorous screening. They are donors and for diseases which would affect long-term renal function. So we can't really extrapolate on the patients who have renal tumors because they often have comorbidities like hypertension and diabetes. These patients obviously are not going to do as well in terms of renal function if we take the kidney out when we can preserve the kidney. And there is data to support that. So after a radical nephrectomy, 29% patients develop EGFR, which was less than 60. 16% developed EGFR less than 45, which is 1 in 6 patients. 22% patients develop CKD after 10 years as compared to 11%, which is expected after PN. And 40%, if you do it in T2 tumors, 40% develop CKD for RN versus 16% for partials. In the MSKCC study, 60% of patients will have GFR less than 60 ml, so that's quite a significant number. And CVS mortality, which is associated with CKD, is 20% at 5 years in patients with radical nephrectomy. These are sobering data, so we need really to think carefully whether the other kidney is fine on CT is actually going to remain fine if we continue the patient follow-up for many years. More than 20 studies, a busy slide. Mean change in EGFR, radical versus partial nephrectomy. Well, no surprises, it favors PN. Of course, the change in EGFR is going to be in favor of partial. If you preserve more nephrons, you are going to have a better function. It really does not need much studies or evidence in a great deal. Again, a meta-analysis of stage 3 CKD with radical nephrectomy versus partial. Again, this favors a partial nephrectomy, more than 20 studies again here. Another argument for radical in complex tumors is that partial nephrectomy involves increased risk of complications and higher blood loss. So why should we bother doing it? If we can counsel the patient that this is a safer operation for you and the other kidney is fine. Now, how risky is the increased risk? Because most complications after partial nephrectomy are not life-threatening. They can be easily managed without endangering life. We talk about increased blood loss in partials, yes, but the blood loss is to the tune of about 100 ml, which might be statistically significant, but is not clinically relevant. We all know as surgeons. Chances of rebleed, angioinfarction, the incidence is about 2 to 3%. I would take the chance if I had, I'm sure all of us would, if any of our relatives had a tumor which was amenable to a partial nephrectomy. We'd just go and select partial nephrectomy and take that 2% chance of having an AV fistula and a subsequent bleed, which can be easily managed by angioinfarction. So these complications are never life-threatening after a partial. And the risk-benefit ratio, when you compare the benefit of improved renal function over long term, will always be in favor of partial as far as renal function and cancer-specific and overall survival, as we'll see in the next data. Now, another argument is that with robotics at a higher center, they might try to save your kidney, but you will have to travel to a higher center, which will be more expensive. This does not hold true for every case, but this is often an argument which is used in, say, remote centers. But it's a question of saving a kidney. So if you counsel the patient properly, a patient would not mind travel the cost or the inconveniences, because after all, if you develop CKD later, the cost of a transplant is going to be almost as much as what you would end up paying for a partial nephrectomy by robotics. A couple of Indians, let's just look at the data now. Trifecta and pentafecta outcomes following RAPN in Indian patients. Trifecta is warm ischemia time less than 25 minutes, negative margins and absence of complications more than grade 2. 60% is for all comers. Pentafecta is trifecta plus more than 90% preservation of EGFR and no upgrade of CKD stage at 12 months. So 24%. So not the data is not that great. I mean, we don't have higher percentages achieving trifecta and pentafecta in our scenario. But for specific instances, when you compare, so this is from Tyagi et al., trifecta and pentafecta outcomes following RAPN for Hyler versus non-Hyler. This is propensity matched. And the trifecta outcomes were significantly worse, mainly driven by the warm ischemia time variable of 25 minutes. But on logistic regression analysis, the Hyler location was not statistically significant for achieving the trifecta. Pentafecta outcomes over long term were similar in both groups. So at 1 year, everything is the same. Warm ischemia time, OR time, EBL, transfusion needs were comparable after propensity matching. So Hyler location is not that great an influence on the ultimate outcomes.
So 1 minute left.
Okay. So I can go across all studies. T2, again, meta-analysis. Operative times, blood loss and complications are more in partials, whereas post-op EGFR recovery, decline in EGFR is less. Cancer-specific survivals, overall survival, all favor partial nephrectomy, and the positive margin rate up to 5 to 6% is there for all partial nephrectomy. So again, this is a systemic analysis for T1B and T2, large T2 tumors, thousands of patients, again the same result, longer operative times, higher blood loss, 97 ml as I said, higher complications, but better OS and better preservation of EGFR. So OS is the most important endpoint, everyone would agree, in oncological operation, and we would be doing that. Feasibility study, positive surgical margin. I'll just take 1 minute and quickly arrive at a conclusion now. Positive surgeon margin rate is 5 to 6%. Complications are not yet great, 13% in this. T1